So, good morning, all. Welcome back to Saturday Club morning meeting. And today we have a very well-known speaker, very popular speaker who has spoken so many times in our Saturday Club meetings when they were held in a physical format. She is Dr. Raha Sarbani. She is a consultant pediatric neurologist at Baroda. She did her MD Pediatrics in 2004 and then did fellowship in pediatric neurology at very famous pediatric neurology center at Hinduja Hospital, Mumbai. She has also undergone comprehensive neurophysiology epilepsy course at Cleveland Clinic Foundation, Ohio, USA in 2011. She was a junior consultant at Pediatric Neurology Clinic, Hinduja Hospital, Mumbai. And to her credit, she has several publications, 6 of them international, and she has contributed chapters to books also. And she has been practicing as pediatric neurologist in Baroda for more than 10 years now. So she is going to talk about indications for surgery in pediatric epilepsy, a very unusual topic for the routine talks that we have. So here we have Dr. Raha Sarbani. Welcome to this online format of Saturday Club. And please go ahead with your talk. You have about 45 minutes, and we'll leave about 10 minutes for discussion. So over to you, Dr. Raha.
Thank you so much, sir. Thank you for those pleasant words on a Saturday morning. So I'll start screen sharing and I'll switch the video off because otherwise it's pretty distracting. So I'll be talking today on a topic which is quite close to my heart. Please feel free to interrupt is the right word, and stop me if we need more information on any particular patient that I'm speaking on. Also stop me if I'm being too fast or unclear about what I'm saying. I'll try to be as comprehensive as possible. I'll be talking about 3 cases, and then we'll look into a little bit about indications of epilepsy surgery and how many epilepsy surgeries have we been able to do in the last couple of years. Of course, the epilepsy surgeries were done at different centers and not at Baroda, but the epilepsy surgery is something where the homework is much more important than the procedure itself. Of course, the procedure is important, but the homework is very important. Now, so 3 cases, indications, and the data. So I'm starting with this first case. I do love to interact with the audience. I like to gauge their response, and only then I feel good that I'm doing a good job, some kind of a reassurance about the talk. So OTT platform, the virtual platforms are very difficult for me because I can't see the participants and I can't gauge the response. But I'll try to be as lucid as possible. So this 2-year-old girl, she had episodes since birth, but they came to me at 2 years. They had, in fact, not consulted any doctor. At present, the episodes were episodes of smiling, followed by loss of posture. So whatever she is doing, anything, suddenly she'll start smiling and will be about to fall. And this will be for a very brief few seconds, 20 seconds, 30 seconds. Suppose she's playing, she'll stop that playing, smile, and would be about to fall. And that's it. There were also episodes of crying and looking lost. So in the middle of anything, she would start crying as if wincing and look lost. Again, very brief. Now they had come now because now these episodes were daily and multiple. Now, obviously, when you see a newborn suddenly smiling, nobody does actually think that something is wrong with it. So although the episodes were present since birth, only in retrospect that had the parents realized that she was doing it since birth and now it's getting worse. Because it's very difficult to say why suddenly a newborn has cried for 20 seconds and then stopped crying. Developmentally, she was normal. Her behavior had started worsening, but she's a 2-year-old and tantrums are always worse at this age. No NICU, family history negative, and only child. Now, this is a very classical history for anyone managing epilepsy. So when I saw her, I almost knew what I'm expecting in her and it's almost like saying that you could predict the future in this kind of a patient. So this is what prediction and astrology must be about, because gelastic seizures, seizures which are associated with laughter or smile, dacrytic seizures which represent as crying, and daily seizures starting very early on. For any epileptologist or a neurologist, it's a classical case of hypothalamic hamartoma. So when I saw, I realized that, okay, this is going to be one of those hypothalamic hamartomas, very difficult situation. And the course for at least a year is going to give me a tough time. So she underwent an EEG, very epileptogenic EEG, and she underwent a neuroimaging. The MRI is showing this lesion here. Yeah, so just above the brainstem on the left side, there is this lesion here, and that is the classical site of hypothalamic hamartoma. Coronal high resolution section, T2 coronal is what we are seeing here. And a coronal high resolution section will be able to pick up a hypothalamic hamartoma. If you see here, this is where it is. So near the mammillary body. So this is the other mammillary body, and this is here it is, the hypothalamic hamartoma. So obviously it was a straightforward diagnosis: gelastic seizures, dacrytic seizures, daily seizures, hypothalamic hamartoma. These are congenital non-progressive lesions that occur from the hypothalamus and during the fetal development. It could be intrahypothalamic and from the posterior hypothalamus and appear near the mammillary body. And the second is parahypothalamic or pedunculated. So our patient had the first type, the intrahypothalamic one. Hypothalamic hamartomas consist of cluster of small neurons. These neuronal clusters are functional unit of epileptogenesis. So they generate the epilepsy and spread it out to the whole cerebral hemisphere, sometimes to such an extent that even the perihematoma area becomes very kindled because of their epileptogenicity. What are the possible options in such a patient? Now, in such a patient, drugs will really not make a difference. Of course, for all practical purposes, we will have to give her 3 anti-seizure drug trials. Drugs in appropriate doses, with appropriate titration, like it is expected for any epilepsy. So it will be initially treated as any epilepsy. So these are episodes, the EEG is abnormal, start the anti-seizure medications. But we do know that these kind of seizures are not going to be drug responsive. So although anti-seizure medications are used in epilepsy secondary to hypothalamic hamartoma, typically most of them will need open surgery, gamma knife radiosurgery, or radiofrequency thermoablation. So in our case, this child was tried on 3 drugs only for 2 months because the drugs didn't make even a 5% difference. She kept getting episodes, and the episodes kept getting worse. And so immediately she was referred for surgery. She underwent radiofrequency thermoablation of the lesion at Amrita Institute, Cochin, because they were from Kerala. They preferred a institute of their own place, wherein the RFA was done. Post-operatively, she did give us a very difficult time. She had immediate seizure freedom, but she had lots of sodium imbalance. It would suddenly become hyponatremic and had suddenly become hyponatremic because we know that the posterior pituitary is regulating the sodium and the hypothalamus was right close to it. So she lost all her milestones of sitting and speaking and swallowing. And the Amrita Institute guys almost had a panic attack that, oh my God, why so much of regression? We do expect post-op regression in hypothalamic hematomas, but this girl had regressed significantly. She also started developing precocious puberty. Now, as we know that precocious puberty is a presentation of pedunculated hypothalamic hematoma, but the hypothalamus, once manipulated with RFA, can lead to precocious puberty. But thankfully, everything started improving after 2 months. The last follow-up, which is 2 months post-op, is when she was sitting and she was playing and she was talking. She has not yet started walking, but she has started eating, she started swallowing. And thankfully, me and the Amrita Institute guys all breathed a sigh of relief that whatever regression had happened was temporary because of the extreme heat used to damage the hypothalamic neuronal cluster. And that's why a little bit of peri-operative site edema. And her precocious puberty is being managed by the endocrinologist here. And she's not having any more of any symptoms as related to that. So she's seizure-free post-op 2 months. She has started regaining whatever loss of milestone had happened temporarily. And she's doing well. Now the next case. Now this one was a very difficult case. She was first seen in 2017, 11-year-old girl, multiple events daily. Now I know I'm talking to you about the very atypical epilepsy cases. I'm also talking to you about very difficult epilepsy cases. But I must tell you that in a percentage, when we look at the percentage of patients presenting with seizures and epilepsy, all these cases put together form a very good percentage. So it individually may appear very rare and insignificant and infrequent, but putting together, they are a huge number in epilepsy. And on a day-to-day basis, I come across patients where they are drug refractory. The drugs are not working and they're still pulling on from one doctor to other, doing doctor shopping, just to try to control the seizures, but not being adequately informed about the surgical option of epilepsy. And so this girl, she came first in 2017, 11-year-old girl. Now she had multiple types of episodes. One was a stimulus sensitive episode. So if she's not noticing and anywhere anything bangs, the window opens, the spoon drops, she would suddenly, the auditory stimuli will give her a tonic seizure, and the seizure will be over and she'll smile briefly. She also had a unilateral limb jerk kind of seizure. She had daily morning episodes while brushing teeth, keeps falling. Whether the oromotor stimulation did it, like the auditory stimulation, nobody knew. She also had huge elastic seizures. She had failed all sorts of anti-seizure medications. She would be falling every day multiple times, because how much can anyone take care that there will not be an unexpected sound? So if she's sitting somewhere and reading, and suddenly someone opens the door and a little bit of sound, but of course, she was lost in her reading, and that sound will give rise to a seizure, and she'll suddenly drop on the bed, or while if she's standing, she'll suddenly plop to the ground because of the tonic seizure. So the parents had to continuously be around her to stop her from falling because of the stimulus-sensitive tonic seizure. Now, there were other things in this girl which were very unexplained. She was a little intellectually disabled, but other than that, she had twice episodes of chronic watery diarrhea, extensively investigated. We didn't know what happened. Also, the brother has a anomaly of the forearm. I don't know whether it is related, but these are the additional history. Now, she was extensively investigated at various centers. Her MRI was normal twice, her FDG PET was normal, and her EEG always showed a left hemispheric focus. Now, when a child is not responding, or any patient with epilepsy is not responding to anti-seizure medications, we try to find out what is wrong. So is there a particular area in the brain which is extremely epileptogenic? Do we find any abnormality in the MRI? If we are not finding any abnormality in MRI, is it possible that it will be picked up in a nuclear imaging scan like an FDG PET, because of the different metabolism of that area? So hypometabolic area in FDG PET. Do we have an EEG or a video EEG which is persistently picking up a particular area, a particular electrode is showing a lot of epileptogenicity? So that is what she underwent at various centers. Nobody was having a clue, because her EEG was left focal, but there was no lesion in an MRI and an FDG PET, and no one knew what to do to her. Now, I'm talking a little bit about vagus nerve stimulation. I know I was talking about the case, and suddenly now I'm talking about vagus nerve stimulation. So we are going through a journey of patients who have epilepsy which does not respond to anti-seizure medications. We try and find out the lesion in such patients, remove the lesion, get rid of the seizures, get rid of the anti-seizure medications. This process is not always very simple, and in NV, in this case where this girl had so many episodes, that was what was happening. We were unable to find a particular site of seizure onset, and we didn't know what surgery to offer to her. Obviously, she's now 16 and she's getting so many seizures a day. She's falling so many times a day. She has been tried in all possible anti-seizure medications. So there has to be a solution to her day-to-day episodes and her completely spoiled, completely disturbed quality of life. So she had already went to 3 surgical centers of epilepsy surgery, and none of them were able to exactly say that what should be offered. 2 centers did tell her that what we are going to do is we are going to try to find a site on the left, in the left hemisphere, by implanting electrodes there and seeing where the seizure is coming from. But the parents were not keen on this kind of they thought this kind of procedure, they thought it's a fishing expedition, which it is not. 2-stage surgeries for MRI negative epilepsy is very much recommended. So that's where vagal nerve stimulation came in. This is a repeated stimulation of the left vagus nerve through implanted electrodes. Any patient with epilepsy demonstrably resistant to appropriate medication is and not a candidate of potential corrective surgery can be a candidate for VNS. The control trials are for patients with partial seizures, and side effects include discomfort in the face or neck, and hoarseness of voice or coughing because of the vagus nerve stimulation. So this is what the device looks like. It is implanted in the subcutaneous area. Its afferent goes to the left vagus nerve, and there is a brief write-up next to the image which tells us how it works. So the theoretical basis of VNS is that when you stimulate the vagus nerve, its afferent connection is to many nuclei, which are part of the seizure network. So if you stimulate it, you'll be able to abort a seizure. Now, this particular device will be put on a particular setting. So it will generate impulses and stimulate the vagus nerve at a regular interval so that the child doesn't throw a seizure, a patient doesn't throw a seizure. Along with that, there is an external magnet given to the patient and the relatives that even after these impulses, if the patient gets a seizure, they can use the magnet and abort the seizure immediately. So an external magnet is also provided. So this was her last VNS setting. And with this VNS setting, the parents reported that she has stopped falling. So the good thing was the parents were now a little free of managing her. They could let her go to school and let her go out of home for 10 minutes, put her out of sight, because after the VNS implantation, she had stopped falling. The seizures have not yet stopped completely, but she's at present only on the second VNS setting. We will be setting the device again after every month or so till we reach the maximum level of setting or we achieve seizure control, whichever comes first. So this is something like an external stimulator, like a pacemaker, like a DBS device, so all working on the same principle. Now this case is the third in this presentation, and this is the last case. I have already presented this case at the pediatric meeting last month, so it could be a repetition of a few of my audience. 3-year-old boy, he was transferred to Kashiba Neuro ICU for acute repetitive seizures. I'll show one of his seizures. So this is the boy, and he's getting this seizure where his left hand and right hand both are going up in a tonic movement. Then he gets these jerks, eyes to the right, and it will stop in a while. So so these were his seizures, and they were daily, many. So acute repetitive means multiple times a day. This was his EEG, very highly epileptogenic on the left side. So the blue are the left electrodes, and these are the right-sided electrodes, and it's terrible on the left side. So that's his seizure, which is starting from the left side. Now revisiting his past history. So this is when he was transferred urgently to the neuro ICU of Kashiba Hospital. But when we went through the history, we realized that he had his first seizure on day 3. At that time, he was already investigated and no cause was found. He had mild speech delay. He had few clusters of seizure off and on in his first 3 years of life. His EEGs were always left hemispheric. His MRI had showed a left parietal lesion. And he was under follow-up with me in the past, but he had recently changed the doctors because there was poor seizure control. So that is what happens. They don't get seizure control and they keep trying to change the doctors. But we doctors are sometimes late in informing them that seizure control will not be achieved with medications. You will have to try the surgical method of seizure control. In this particular patient, I had advised pre-surgical evaluation, and due to the apprehension related to brain surgery, they had changed doctors to find out whether drugs will still be working. He had failed drugs. He had early left-handedness. So we are seeing a seizure. The seizure is not telling us that the seizure is originating from which hemisphere. So whenever there is a seizure, if we see a right hand jerk, we know that it probably is coming from the left hemisphere. But all seizures will not tell us that where they are coming from. The lateralizing and localizing sign of every seizure may not be very clear. In this particular child, except for the eye deviation to the right, nothing points to the left hemisphere in the seizure. His EEG is from the left hemisphere. He is left-handed to suggest that he is right hemispheric dominant. That means he always has left hemisphere pathology. His MRI is from the left hemisphere. So now this is a very ideal surgical candidate because the data is very concordant. EEG is left, MRI is left. Now, how much on the left hemisphere should be removed? Back to the present, he failed all injectable anti-epileptic medications. He was not tried on coma-producing medications because he was conscious in between the seizures. That's his MRI. This is his left hemisphere, looks slightly different from the right hemisphere. But there's nothing glaring at us except a little bit of fuzzy area here. Again, we are not finding any particular area of abnormality. There are few fuzzy areas. So it was reported that fuzzy gray might matter differentiation in the left parietal lobe. Also, left insula and left basifrontal shows some gray might matter irregularities. Now, how to operate in such a patient? A little bit of area is abnormal in left parietal, a little is abnormal in left insula, left basifrontal. What surgery to advise? Is he an epilepsy surgery candidate? Yes. Should we insist on emergency surgery? What else can we do? The drugs are not working. Where to send and how? Because he's getting seizures 50 times a day. So we managed a pediatrician from Neuro ICU Kashiba, got him transferred to Mumbai for epilepsy surgery. He had interminable seizures even in Mumbai at Hinduja Hospital. They did a nuclear imaging scan and it showed that the entire anterior part, the frontoparietal part of the left hemisphere, is hypometabolic because of seizures continuously happening from that area. So if you see, the left hemisphere is pink and red, but again, it is an extensive area. So look at this whole part. Which surgical procedure should we do? Should we spare the motor cortex? How much should we dissect? If we do limited surgery, will he come back with seizures? So we went for hemispherotomy. So we disconnected the entire left hemisphere because it was becoming impossible to decide whether we will be able to make him seizure free if we spare the motor cortex, if we spare the visual areas. And emergency surgery, the recommendation is hemispherotomy. A left hemispherotomy was performed. Post-operatively, he developed right hemiplegia. Physiotherapy was started and 3 AEDs were continued. These are his post-op scans. So this is a post-op scan and we are seeing there is edema there because of the post-op period. And the connection has been removed between the corpus callosum, between the commissures. This is his tractography post-op, which is showing how the tracks have been disconnected microscopically. This is the diffusion tensor imaging or a tractography, showing us the tracks have been disconnected on the left hemisphere. So the output starts here. So this entire area is not giving a significant output. This is a post-op EEG showing isolated island of seizure on the left side. Of course, it is not getting spread to the rest of the hemisphere, and it is not getting spread to the opposite hemisphere. This is his post-op video. He's seizure-free. He has a hemiplegia. Oh. So he was always left-handed and he's still using the left hand. But of course, he has a hemiplegia, which is improving with therapy. And that's my OPD in Kashiba. I have no idea why there is a skeleton there, but I'm quite happy with the skeleton. We cohabitat. Patients with refractory status epilepticus are emergency surgery candidates. Emergency surgeries may be required for hemimegalencephaly, focal cortical dysplasia, or Rasmussen's disease. Now, a couple of slides about selection criteria for candidates for epilepsy surgery. They should have an established diagnosis of epilepsy. They should be refractory to drugs. The seizures should be debilitating, or they may have recurrent status. There should be a localizable epileptogenic region with a brain MRI supported by video EEG or functional imaging. Parents should be informed and motivated. Progressive disorders are to be ruled out. Of course, Rasmussen's is an exception. It's a progressive disease, but surgery is recommended. High likelihood of improvement of quality of life with seizure control should be expected. Only then surgery should be recommended. When we are trying to find out the area which needs to be operated on, we take information from various investigations and modalities, put them together to find the epileptogenic lesion or the epileptogenic zone. So this is how we narrow it down from the broad area available to the exact area which will need to be operated on. There are various types of surgery. Resective surgery is lesionectomy, that a dysplasia will be removed. Hemispherotomy is also resective surgery. Disconnection surgeries are corpus callosotomy, only the corpus callosum is disconnected, and neuromodulation like VNS. Now, this is the data from last 2 years. I've been practicing since 2013. And only in last couple of years have patients finally started understanding the need for epilepsy surgery, and they've started giving the consent for it and started going for the workup. So 5-year-old JP underwent a lesionectomy for focal cortical dysplasia. He's seizure-free now. He was always a little slow and is still slow. 10-year-old CP underwent tailored lesionectomy. He had MRI negative epilepsy. He is also having a genetic disorder which associates dysplasia with epilepsy. He is having infrequent seizure in last 6 months, but it is only 6 months post-op, so maybe he will do better. IJ, we just saw the case, 2-year-old girl underwent radiofrequency ablation for hypothalamic hematoma. She's seizure-free now. AR is the patient we saw for emergency hemispherotomy. He's seizure-free now, has hemiplegia. SP, 8-year-old girl underwent anterior temporal lobectomy for mesial temporal lobe epilepsy. She's seizure-free now. DC, anterior temporal lobectomy for a patient with MTLE in a case of neurofibromatosis. I don't have her follow-up. They have not been regular. This is an unfortunate case. 14-year-old YN, he underwent corpus callosotomy for symptomatic LGS. He was completely seizure-free post-op. Accidentally, one day the parents left him alone at home for a while, and he had accidental drug overdose. He had started taking all the medicines, his anti-seizure medicines, which he regularly took. He took a fistful of them, and he could not be saved. And we 16-year-old who underwent the VNS. So, thank you so much for this for a patient hearing. I know it must have been too much of information. I did try to bring out the cases which would interest you. I want to say that epilepsy cure has to be looked beyond anti-seizure medications. Surgical options have to be promoted, or rather considered, and a rational treatment should be given.
Thank you, Dr. Raha. You can stop the screen sharing and switch on your video for some interaction. Yeah, thank you very much. Thank you very much, because I realized that you are not well actually, and still you.
No, it's just a hacking cough. It keeps coming.
As usual, it was very comprehensive, and no doubt, I mean, however difficult it was, I mean, you made it quite simple. At least for the pediatricians, no, it was easy to understand that what are the indications for which we can think about surgery. So now it's over to audience. There is one question. Let me look at the chat. Dr. Shulin is asking, what is the incidence of refractory seizure children population needed to undergo surgery? And what is the medical treatment window period before deciding for surgery?
So the question does tell me that someone was listening. So thank God. This virtual platform is so difficult.
We were all listening. We are all listening.
Yeah.
You should have kept video on.
Yeah, I get very conscious with the video.
You not only talk.
I know, but
lots of gestures.
I get very conscious with the video. So I mean, I switch it off for my own benefit, that I should not keep looking at my own face, behaving very narcissist-like. So yeah. So coming to the question, adequate dose of drug in the right indication. So if we are saying that we found a focal seizure and we are trying valproate or levetiracetam and it is not working, then we are creating wrong drug refractoriness. So first thing is we have to confirm epilepsy, of course. Second thing is the right drug refractoriness, means we chose the right drug, we gave it in the right dose, we brought it up to the right level of tolerance, acceptable to the patient. We tried the correct drug combination, and then we did not achieve seizure freedom beyond 2 or 3 correctly chosen anti-seizure medications, then those patients are to be considered drug refractory epilepsy, DRE. Now, drug refractory epilepsy is very high in the epilepsy population, pediatric population, but not all of them are surgical candidates. Some may have drug refractory genetic epilepsy. Some may have drug refractory epilepsies because of bilateral lesions like tuberous sclerosis, the commonest example. Tuberous sclerosis has lesions all over the brain and they are drug refractory so many times, but they have so many lesions. And then we have to figure out which lesion to operate on. Of course, we do operate even tuberous sclerosis. Drug refractory due to bad perinatal lesions. So neonatal hypoglycemic brain injury, HIE, so many lesions, but not a surgical candidate, too many lesions to operate on, So drug refractoriness is common. True drug refractoriness has to be decided. So it should not be that it is a pseudo drug refractoriness. And not all refractory epilepsies are surgical candidates. So the surgical candidates have to be chosen.
Before going for surgery, can you try radio frequency ablation?
No, now the radio frequency ablation is also a surgical procedure, and it is not recommended for epilepsy surgeries other than particular indications. So hypothalamic hamartoma was a particular case scenario where RFA is recommended. But otherwise, radiofrequency ablation and gamma knife radiosurgeries are not recommended in any epilepsy surgical candidate. Most of the time, it has to be an open surgery. The hypothalamic hematoma is an uncommon indication for this.
Dr. Sulin has another question. If I understand correctly, it is probably he's asking about atypical febrile seizure protocol after age of 5 years.
Oh, yeah. Off late, I don't know what is happening. I'm getting all sorts of late onset febrile seizures. 6-year-old, 7-year-old, 8-year-old, first febrile seizure, second febrile seizure. So I think anyway, the ILA and the various epilepsy bodies had removed the upper limit on febrile seizure, because they also realized that sometimes they come at 8 also and 9 also. So the upper limit on febrile seizures has been removed. Now, for all atypical febrile seizures or for seizures which are febrile seizure plus, like genetic epilepsy febrile seizure plus, I personally, I know I'm talking about personal experience. I'm not talking about what is the study available, but I personally think that if the interval between two seizures is beyond 2 years, there is no point in starting drugs. We will be giving drugs for 2 years, and the interval is beyond 2 years, then what is the point? So unless they are frequent, unless I'm expecting status epilepticus, unless I'm thinking that there is a family history of seizures which have always given us trouble, I do not start anti-seizure medications in late onset, atypical, or whatever the febrile seizure is.
It's a good message. There is something regarding EEG teaching. Is there a module for general pediatrician for EEG? I do not know whether it will. You are.
Yes, can there be a module? Now, there used to be this PET1 series. We did it once in Baroda. This was from the British Pediatric Neurology Association, BPNA, and they had this PET1 module, Pediatric Epilepsy Training 1 module. PET1 is the simplest module, and it is very good for pediatrician. We did it once. I think we did it in 2017 or something. I don't remember. But unfortunately, after 2 years of doing a lot of PET1 across India, BPNA had some kind of a fallout with the Indian organizers, and we have not been able to carry it on. But yeah, that was a very good module. As far as any other module is concerned, they are very, there are many, each body comes up with a module, AOCN comes up with a module, and pediatric neurology chapter of IOP just comes up with a module. But those modules are also very good, but they're not very consistent. Every time they're not happening at a regular interval. Like you can say that every 6 months this is the module happening, or this is how it would be. But yes, anytime there is a module, I will inform you. But I wish the PET1 could have been continued. We'll see whether it still can come back to India.
I do remember having attended the PET1 in Baroda.
It was a good one. It was a good module.
What Dr. Sulin was asking, I mean, this is a good information that you said, but he was asking about EEG teaching. Do we actually, my question is, do we really need to learn EEG? asphyxiation.
No, we may not need to learn EEG, but we may not need to know something about EEG. See, why I'm saying this is that suppose we are absolutely unaware of a particular test, how it is done, how it should be done. What, for example, when we do a blood test, we have its normal range, right? So we need to know that normal range. So what is the normal range of the EEG? So by normal range, we can't have a value, but we should know what should be the graph looking like. So I'm not saying we need to know every graph, but we need to know that is the right electrode being used or is it? So why? So either we send it to, I know I'm quoting Toprani, but still I'm not promoting Toprani. So either we send it to a lab where देखना नहीं पड़ेगा भाई कोरोना मेरे को नहीं पता है. You know, what is the normal machine used for homocysteine, whether homocysteine has been done at the right temperature, the sample collection was correct or not, the range, did you check with the control? I don't know. So either close your eyes and send to a lab where we know that they are following the standard international recommendation. So same thing is for EEG. So either we know about it and we get it done from a place, any place, because we know about it, how to interpret it, or how to make sure that the EEG has been done in the right way. Or we close our eyes and send it somewhere where the standard method of doing the report has been followed. This is applicable for any test. I can't say that I have no idea about nuclear imaging because I am not supposed to be doing nuclear imaging. But my patients, if I'm recommending an 18,000 rupees test, how can I be saying that I don't know whether it will be followed by the right procedure? So either I pick up an institute where I have got the recommendation from many places that they are following that the right standard, or I know about FDG PET and find out. So I think you're right in asking the question that yes, we should know about EEG. We should know whether we did the correct thing, this is how it should be done, or whether it's just a random test.
Some basic knowledge we should have.
We should know.
Right. And Dr. Rajan Chanpura has said that digressing from the topic a bit, but recently we have had a slew of necrotizing encephalitis. Your experience with this?
Any viruses, when they will come in the community, suppose there are one necrotizing encephalitis which you see in the ICU, for every one necrotizing encephalitis, you will see 1,000 in the community with that virus. Now, this is simple logic that when any infection in the community, the percentage has risen, the complicated of infection will also rise. So right now, yes, you are right. Dengue and H1N1, the community percentage of these viruses right now is so high. Dr. Satish Pandya will vouch for me, he'll know better. So if you have 1,000 dengue in this OPD, you will have 3 A&E in the ICU, because obviously it is a matter of probability. Yes, it has a viral association. It's all dengue and H1N1 and all that.
Lot of viral infections.
COVID, all viruses. It's just a cytokine storm, basically. So which host will respond how to a virus? And some host will respond badly and get an A&E.
Right. So I think that there are no more questions in the chat box, and if there are no comments or questions, I think we can end this session here. Once again, thank you, Dr. Raha, for spending your time in the morning, and we look forward to some more talks in the future again.
Thank you. Thank you for inviting me. It's always a pleasure to speak on this platform. All stalwarts, seniors, really makes me feel very good. Yeah.
Thank you so much.
Thank you.
So we meet next Saturday again. We'll have Dr. Udgit Thakur, an intensivist, talking to us about some salient things about intensive care. So we meet next Saturday morning.